Welcome to the Rare Info Series, episode 71. In this episode we have the speaker, Dr. Pradeep Kumar, MD, Consultant Clinical Geneticist, GeneOmm, Center for Genetics and Rare Diseases, Coimbatore. We will be exploring hereditary cancers in greater depth, including how they are decoded through genetic testing and family history analysis.
Mind, you ask this question in your mind whether cancer can be, all the cancers are genetic. Is it right or wrong? So all the cancers that happen to a human being has genetic basis. The only question is whether they are inherited or not. So that means any cancer cell is due to a mutation that has happened in the cells of that organ. Whether this mutation is initiated by the inherited genes or it has happened only in the organ, that determines whether this is a hereditary cancer or not. So I would say this cancer is a genetic disease. The question is whether it is limited to certain region or it is because of a inherited genetic abnormality. So the genetic basis behind my concept, concept I say that cancer is a genetic disease is body cells grow uncontrollably, and that we call as cancer. If the body cells grow controllably, that is called growth. So to grow from a child to an adult, we need this multiplication of the cells, and the multiplication is governed by several genes. The signals for multiplication are given by genes only. And in cancer, these cells grow uncontrollably. That means the governance of the cells, governance of the genes for this multiplication is altered. So unregulated proliferation of cells and confusion in cell division and cell death is what we call it as cancer. And this multiplication, this cell division is controlled or governed by several genes. So there are genes which are responsible for cancer. These are called oncogenes. These genes will be normal. On exposure to some offending agents, they get mutated. Once these genes get mutated, they give rise to cancer. Another group of genes called tumor suppressor genes, as the name implies, their work is to suppress the tumor origin, or if tumor cells are there, it has to go and suppress them. Another group is DNA repair genes. Our DNA undergoes regular mutations and these are repaired by these genes. If any mutation has happened in these group of genes, then you can expect cancer in an individual. So in the introduction, Dr. Beena said, when a family comes to us, when there are multiple members of cancers in an OPD, say 100 patients with a cancer, you can expect 90 to 95% of them will have no inherited mutations. 5 to 10% can have inherited mutations. They have genetic cancers. So at least 1 out of 10 will have an inherited cancer mutation. So why is it important to know whether it is somatic or germline mutation? Somatic mutations, the 90 to 95%, the common one, multifactorial we say or idiopathic we say, they have the mutation that has happened only in the organ level, the cellular level, tissue level. This mutation has happened after the baby is born. This is not related to the genes at all when the baby is born. So it means that area is affected. The mutation, the cellular multiplication happens only in that organ. It is confined to that organ. These are called somatic mutations. The most important thing is they have no inheritance. A person with a somatic mutation, their offspring or their sibling are not at high risk for getting the same cancer. The other group, 5 to 10% group, about whom we are talking about today, germline mutations, the genetic abnormality is there in their blood when they are born. So they would have come from parental gametes in the embryo level itself. So this gene is spread over in the entire system of your body. Entire organism carries the mutation. It is not limited to one group of cells or one organ. So they can get expressed in the gametes of the individual. That means this will be inherited to the next generation as well. So the most important thing is, though this is 5 to 10%, this has significant recurrence risk into the offsprings, and their siblings are also at risk because they can share the same genetic mechanism in them. And another thing is, this is confined to one organ, but this germline mutation are not confined to one organ. It is spread over the entire body. Wherever the gene has expression, then that organ is at risk. A person, a female, has a breast cancer now, but if she has a mutated gene which is responsible for the breast cancer, she may be at risk for ovarian cancer later, because in ovarian tissue also the same gene mutation is there. So once you know this, we know that there is a risk for another cancer in the same individual, or there is a risk of cancer in the sibling or also in the offspring. So 8 to 10% of cancers are hereditary. So who should we test for inherited cancer? 10 patients are coming inside. How to select a person for germline mutation? There are various guidelines, ACMG guidelines, which we regularly follow, and NCCN, National Comprehensive Cancer Network's guidelines. Here they have given all the indications where we have to apply this germline testing. So whom to test? There are several criteria: early onset breast cancer, bilateral breast cancer, triple negative, less than 60 years, male breast cancer at any age, high grade serous ovarian cancer, early onset. So the list is big. Family history, that is very, very important. Family clustering of any cancer type is very important to note. So you know that this is running in the family. There are so many persons affected with various different cancers also. Then you know this is running in family. It can be hereditary. So same way, more than or equal to 3 first or second degree relatives with breast cancer, more than 2 affected, but at least 1 diagnosed at less than 45 years. There are so many criteria. So Amsterdam criteria helps us to identify in colorectal polyposis, where we can pick out the high risk population. So in general, what we have to notice, in the family history, there are several first or second degree relatives with a common cancer or related cancers, or 2 family members with the same rare cancer, or an unusually early age of onset, bilateral multifocal tumors, 2 primaries. One primary got treated, later on they develop another primary, or tumors in 2 different systems in the same individuals. Other cancer syndromes like tuberous sclerosis, neurofibromatosis, or ataxia telangiectasia. So in all these conditions, we have to think of germline genetic testing. So concepts, how to apply this genetic testing. You have selected a patient, how to go about it. Who should we test? Like in genetics, index patient is the first person who should be tested for any genetic testing. Same way, mutation detection in germline cancers also to be done in the affected family member only. There may be an affected family member, a maternal uncle. This person would have come to you. They will ask you whether I am at risk. I want to get tested. It is ideal to test the maternal uncle, look for the unique code, the genetic code, and recheck in this person. That will be ideal to do. If that person is no more, then the screening can be applied for the asymptomatic individual also. At-risk individuals should be offered genetic testing based on index patients' reports. So once you know the index patient report, you can recheck in the at-risk asymptomatic individuals. So there is you should not do it for the sake of testing. If you do some testing, it should be applied and it should help the family for something else, like early diagnosis, prevention, or in the treatment also. So unless you have these indications, don't rush them towards genetic testing. And for children, they should be tested only if the malignancy can develop early in the childhood. If it helps improving the outcome by prevention. Otherwise, routinely checking children for adult onset cancers also is not recommended. So we have selected the family, we know the concept, we have selected the person, and now what test to offer? As in genetics, there are multiple testing options available. Gene panels comprising of germline cancer panels, cancer-related genes. Clinical exome covers around 4,000 genes. Whole exome covers around 22,000 genes, or whole genome. All these options are available. There is another group of testing called MLPA. This detects deletions or duplications. The next generation sequencing detects spelling mistakes. So point mutations, all these things, nonsense, missense mutations, all these will be covered in next generation sequencing, point mutations, but MLPA will cover deletions and duplication. There are comprehensive tests available where sequencing along with MLPA will be done. So it is ideal to go for a wider testing, like comprehensive testing, where you can add sequencing and MLPA. Most of the time, we see families come only with next generation sequencing. For BRCA, say for example, BRCA1 and BRCA2, there are deletion duplication comprises about 5 to 7%. If you do only sequencing, this deletion duplication will be missed. It is always better to give a complete coverage testing. So when we talk to the family, this is called pre-test counseling. We know what are all the indications, we have to explain to them. This is why we have selected you for the genetic testing. And these testing options are available. This is the coverage of the test and this is the cost of the test. And most importantly, where you are going to send is also very, very important. The person, the bioinformatics team, the lab team also is very, very crucial in getting that results. This person, this celebrity, when we talk about germline genetic testing, we cannot miss this celebrity, Mrs. Angelina Jolie. She's a famous actress. She knows that her mother and her aunt had cancers, ovarian and breast cancer. They were not tested, but she did genetic testing on her and she found that she was positive for BRCA1 gene. And knowing that, she underwent risk reduction mastectomy. This was a sensation. This information spread like anything, and the cancer clinics were full. There were so many people rushing to get their genetics tested as they had family history. This is called Angelina Jolie effect, and a study has been done and published by Gareth or Evans et al. Breast cancer in India. What is happening in India? India has the lowest survival rate for breast cancer patients. Every 2 women diagnosed with breast cancer, one is likely to die because of various reasons. But again, in US, 1 in 6 dies, or in China, it is 1 in 4. So breast cancer can be hereditary in 10%. So imagine if in 1.5 lakh women who are diagnosed with breast cancer, 5 to 10%, that means 10,000 may have familial cancers, which should have been prevented if we know the family history or we know some high risk population if we identify. So early detection of breast cancer helps increase the survival rate by doing early diagnosis and early simple management. And in India, we always think if it is breast cancer, do BRCA1 and BRCA2. That is enough. No, in a study in India, BRCA constitutes about only 70% of among inherited breast cancer. That means 30% are other genes. So BRCA1 and BRCA2 combinedly, they comprises about 70% only. There are so many other genetic mutations. So it is always wise to do multiple gene testing at once so that you will not miss the exact genetic abnormality. So there are big list of genes associated with germline cancers available in all your commercial labs. You can ask them and then get tested. Idea is don't limit yourself to few genes. Do a wider testing, give a better coverage with sequencing and deletion duplication testing, and then we'll get the proper results. So what we do in our genetic clinic, genetic evaluation, as always, starts with a pedigree, detailed family history, where there are any family members who are affected and what sort of cancers they had, any history, any details from them. All these reports we will take from them. And the pre-test counseling, as explained earlier, we talk about why this testing is needed for your family and what I'm going to offer after getting the results. So once the results are ready, then we will review them with the results. Post-test counseling involves reading the results. If we know it is a pathogenic or likely pathogenic mutation, between class 1 and class 2, we are very sure that this is the mutation, this has caused the abnormality. Then we can plan treatment and surveillance protocol. So we can advise specialized medical or surgical management. Surgical managements like risk reduction surgeries are coming up in a big way. So BRCA1, BRCA2 positive families, we can advise risk reduction mastectomy of the unaffected breast, risk reduction oophorectomy. All these can be offered based on the genetic testing so that you can reduce the risk of another cancer in these organs by about 90% to 95%. So surveillance strategies can be planned and risk assessment of the at-risk family members. So you are taking care of this person who has got the mutation. We are taking care of the affected expected or at-risk family members like the siblings or offsprings. We can go test these family members. We can literally divide the family into two. Who is carrying this mutation? Who is not carrying this mutation? Person who is carrying the mutation, we can start them with the surveillance protocol. Like we can specialize surveillance according to the gene identified. The at-risk organs will be screened, and the idea is to pick up cancer or abnormal growth at the early stage, so that the treatment will be very, very simple. And most importantly, there is no need to panic for the at-risk family members who are asymptomatic, because we will explain them that having this mutation alone doesn't make you vulnerable. That it is not sure that you are going to get this disease. You are at high risk. Let us be practical. Let us use this to our advantage. We will evaluate you. We will try to find out at the earliest and treat you if something comes up. If nothing is there, well and good, you will be asymptomatic throughout the life. So having that mutation doesn't mean the person is going to get the disease. So they are at risk only. So management strategies, once the mutation is identified, we can sit and plan with the primary team, the oncologist, oncosurgeon, radiotherapist, with radiologist also, for treatment, prevention, early identification, and anticipatory guidance options. So we sit with them, talk to them, and we will give a proper surveillance protocol. For example, for breast cancer, tamoxifen, raloxifene, olaparib, all these medications are coming up for secondary prevention. Ovarian cancers, oral contraceptives is used. Risk reduction surgeries, as I explained, mastectomy, salpingo-oophorectomy can reduce the risk of another cancer by about 90%. So risk assessment for at-risk family members, extended family members screening, and if somebody is found to be having the mutation, they can put into the another surveillance protocol. So prevention for the offspring by prenatal diagnosis during next pregnancy, and here this can be offered only for mutations which can cause childhood cancers, not for the adult cancer. So prenatal diagnosis can be offered. Some situations we can do PGT. PGT can be done in the embryos, and embryos without some adult onset cancers we can transfer, but not prenatal diagnosis cannot be offered for a adult onset cancer like BRCA. But in case of TP53, Lee-Fraumeni syndrome, where you expect a childhood cancer, you can offer prenatal diagnosis. So for example, surveillance protocol for BRCA1 mutation, regular monthly breast self-examination, and then biannual clinical breast examination, 25 years, MRI and mammogram from 25 years of age, which usually we do from 40 years of age, biannual transvaginal ultrasound, serum CA125 marker from 30 years onwards. So all these are done before, and it will be done frequently, so that we won't miss any new cancer starting in the person. So surveillance for men also will be discussed with them, discussing about prostate screening, looking out for changes on the skin and chest area. So the other group, variant of uncertain significance. This is very, very important. In genetic testing, we are getting around even 20 to 30% of the situations we get variant of uncertain significance. This is a big headache now. You can do the testing, but reading the testing, particularly in situations like variant of uncertain significance, is very, very difficult, and it puts us, the primary physicians, into so much of pressure, and also family into so much of anxiety. So mutations are doubtful or negative. Negative, we don't worry, because this is negative, we have to keep the patient under follow-up, regular follow-up only. But the mutation is doubtful. What does it mean is, we don't know whether this is applicable now or not. We lack evidence for this mutation. We cannot do we cannot proceed with irreversible decision making like surgeries based on this mutation. This is what it implies. So this mutation, if it is doubtful, we have to see whether we have completed all the genetic testing for that or not. If something is pending like MLPA, we do the testing and then complete the testing and sit back. So if the family segregation analysis can also be done, another family member has the same cancer, we can check this mutation. If it is negative, that means this is not the mutation running in the family, something else may be hidden, or it is a somatic mutation. We can do functional studies based on this. We can apply and see. All these does not happen in one setting. This needs regular follow-up. If nothing is working and everything still remains a variant of uncertain significance, this family, this person has to be under regular follow-up with the genetic consultant, at least 6 months to 1 year. Once we can do reinterpretation, reanalysis of the data, and if this turns out to be pathogenic, we can start acting on it. So the percentage of variant of uncertain significance turning out to be pathogenic or likely pathogenic is around 10% only now at present. So 90% of the time it remains doubtful only. So with doubtful mutation, don't label them, don't take irreversible decisions based on the doubtful variations. So here again, reliability of the labs, competence of the bioinformatics team is very, very important. So another 20 minutes, I'll take you through the clinical implications and a few case scenarios, then we can wind up. So a 44 years old female, she came with medullary carcinoma of thyroid. So this warrants genetic evaluation because this disease itself warrants genetic evaluation. This is an indication. So family history of cancers were present and cancer type was not known in the family history. So this again is a second indication we have, and genetic testing was done. RET gene genetic mutation was found to be positive. Once we identify this, we can check the siblings, we can check the offsprings, whether they have this mutation or not. If they are having the mutation, then they have to be under surveillance and follow. This patient was put under surveillance, annual serum calcitonin, plasma CEA, plasma Phe, metanephrine, sinus calcium levels, all these will be done annually. And if something is abnormal, then maybe imaging studies will help to know whether new origin of cancer is there or not. I'll take you through few case scenarios of breast cancer. 52 years female, breast cancer, central nervous system metastasis. So late presentation, the triple markers were negative and family history was there. Maternal uncle died at 45 years due to central nervous system cancer. They don't know what cancer. Genetic testing was not done. So there is a strong family history, young age, central nervous system cancer. This person 52 years and genetic mutation was identified. So then this person can be put under surveillance after treatment, and family members can be rechecked and they will be put under surveillance. We will not face this metastasis, long high grade tumors in this family because we know the mutation, we know the at-risk family members. We are going to screen them. We are not going to allow them to an end stage or metastatic stage. Another family, 30 years female, invasive ductal carcinoma, now no family history at all. So 30 years female and genetic testing showed BRCA1 mutation. What next is again treatment options, surveillance for this female, and what next is do the testing in the siblings. So her sister, 35 years old, she's asymptomatic. So she was offered this genetic testing and she was found to be positive. Now we can put her under surveillance protocol and risk reduction surgical options are explained to both the sisters and parents. Parents will be relatively young, 34 years and 30 years females. Their parents will be around in the 50s. They also have to be screened so that we don't want to miss any mutations in them. They can be put under surveillance so that they will be effectively prevented or treated early if they have any cancers. 42 years old mother. Whenever I present a germline cancer mutation, I will talk about this family because this family is an eye opener for me because this has everything. This family has everything. What germline mutation testing we need to know, everything is there. So 42 years old mother. See, she conceived by donor ovum. She delivered a normal female baby. So donor ovum, normal female baby. Mother had bilateral mastectomy, bilateral breast cancers, 2 primary breast cancers. This is an indication here. And because of this, they have taken the donor ovum decision. Okay, done. So baby is born, baby is normal. Previous 2 babies died due to central nervous system cancer at 17 and 10 years of age. So look at this mother, bilateral primary breast cancers, bilateral primaries, 2 children died of central nervous system cancers. They didn't have any reports. And I was able to trace these reports because they were admitted in a neuro center of my friend's own neuro center. I was able to get that and found that central nervous system cancers they had. So now mother conceived by donor ovum. There is a normal female baby. Now they are apprehensive about this normal female baby. Family is worried about susceptibility of cancer in the baby. So what to do now? go test the female baby, normal female baby, or go test the mother, or don't offer any testing because donor ovum is there. So I'll present you the pedigree here. So mother is married consanguineously. She has married her maternal uncle. So second degree consanguineous. And two children died. This is the newborn born out of donor ovum program. So now if you see whether to check this newborn or not, or we will just leave it, we cannot, because this mother has some genetic mutation, genetic germline cancer gene in her. Her donor, her ovum is not used, but her mother's brother is her husband, his sperm is used. We don't know whether this person from the same family is a silent carrier or not. So this newborn is still at risk, because if this person is a silent carrier of this mutation, she will be having the mutation. Now, where to start now? The question is whether to do genetic testing in the newborn. No. So as I said earlier, the genetic testing has to be offered for this person who is affected, who has bilateral breast cancer. So genetic testing was done in her, and we found out this TP53 mutation causing Lee-Fraumeni syndrome, very dreaded disease, and this mutation has been identified now. So mother has this mutation. So should I go and test this newborn now? The same mutation, can I recheck? We can do, but most importantly, another person at risk is her husband. If he has this mutation, he is at risk for cancer now. So we checked the husband as next level, and he was found to be negative for the mutation, and the newborn was not offered the testing. Mother was put under surveillance. So this is how we have to evaluate in a family with this sort of scenarios. In colon cancers, 59 years old, born to third degree consanguineous, colonic polyps, adenocarcinoma. This mutation is an autosomal recessive mutation, homozygous, heterogenic. This homozygous, unless there is consanguinity, it is very, very unlikely it will be transmitted to the offsprings, but the siblings can be at risk, and we can test the gene there in the siblings. Another group, multiple colonic polyps, no family history, parents non-consanguineous. The same colonic polyps, the mutation is APC gene mutation. This is autosomal dominant. Here it means whether the partner is carrying the mutation or not, this person is going to transmit the mutation to the offsprings. So we can do testing with the siblings and the offsprings, and this person will be put under regular follow-up after basic treatment now. So 16 years old female, brain MRA, showed features suggestive of cerebellar glioma, and there are so many changes in the brain. This was suggestive of, and she had multiple cafe red spots. Genetic testing was done, and she had neurofibroma. This again we know is a precancerous condition, has 50% recurrences. Without cancer, sometimes they are prone for multiple seizures if they have lesions in the brain as well. So neurological developmental abnormalities can be seen rarely also, and they have multiple neurofibroma, plexiform neurofibromas later on. So another family, 23 years old pregnant woman, presented with multiple cafe red spot, like the previous case scenario. And she is at 23 years old, 10 weeks of pregnancy. Skin lesions started increasing in size, plexiform neurofibromas, and hearing is normal. So 23 years, unevaluated, 10 weeks of pregnancy, they came to know about the risk of this fetus. So whom to test now? Shall I go test the fetus directly? No. We have this person who's affected. Go test this person. We did the genetic evaluation, and neurofibroma, one mutation was found out, and we know that the fetus is at risk for this. 50% is the recurrences, autosomal dominant disorder. So prenatal diagnosis was offered, and fetus was found to be negative for the mutation. After seeing these two families, I saw another family. Mother had plexiform neurofibroma. One child, 3 or 4 years old, with multiple cafe spots. Another child with 9 months old with multiple cafe spots. You have 3 family members with neurofibroma where prenatal diagnosis or genetic testing was not done. So this is an unfortunate situation again. So this would have been prevented if you would have done the genetic testing at the right time. This is a very, very interesting family. Non-consanguineous couple, family pedigree showed 2 childhood deaths in the maternal uncles of unknown cause. Mother, her mother's brothers, 2 of them died in the newborn period. This family came to us with first baby died at 10 months of age, normal till 10 months, had short febrile episodes, seizures, dehydration, died in 2 days. Obviously, pediatricians thought of inborn errors of metabolism, organic acidemias, nothing turned out to be positive. So genetic testing not attempted, but basic inborn errors of metabolism screening was negative. They went ahead with the second pregnancy, and this pregnancy, this baby died at 9 months. The second baby was irritable since birth. On evaluation, had Wilms tumor. Biopsy showed round cell tumor, treated for the same, and deteriorated and died later at 9 months of age. Genetic evaluation not done, DNA not stored. This is the situation here. Two maternal uncles died, no reason, no cause. Two babies died here, no genetic evaluation done. One unknown, crashed in 2 days, another one had Wilms tumor. So the family presented to us for pre-pregnancy, for planning next pregnancy. So now, as I told you earlier, the best person to test is symptomatic person. No symptomatic persons, any genetic material is available with us. So the best person to test is the index child. However, DNA was not available. So there is a custom of storing this dried umbilical cord from the baby. So in our area, and we asked for that. Luckily, it was available with the mother. The dried umbilical cord was subjected to DNA extraction, and luckily again we got the DNA extracted from it. 30% of the time we succeed in doing this. A 9 months old baby's genetic testing was attempted by whole exome sequencing. We found a pathogenic mutation in SMARCB1 gene causing autosomal dominant rhabdoid tumor predisposition syndrome. This explains the cancer in the second baby also. So parental reconfirmation by Sanger sequencing was done. Mother was found to be carrier of the same mutation. You can assume here mother may be a silent carrier. We don't know. Maybe these maternal uncles would have carried this mutation. But since the mother is having this, she's remaining silent. She needs surveillance as well. And mother was put under surveillance protocol. So the recurrence risk for this is 50%. Now we've got the genetic mutation of the family. We have identified, cracked the genetic code. Now we are ready for the amniocentesis, and amniocentesis was done, and the third baby was found to be normal. So we have reassured. This is how we evaluate. The option of extended family member, that is mothers, brothers, sisters, we've offered genetic evaluation, and mother was put on surveillance protocol, and this case report has been published as well. Another family, a child with bilateral retinoblastoma. Development and intellect were normal. Most of the retinoblastomas, isolated retinoblastomas, intellectually they will be normal, development will be normal. Baby of R was evaluated for genetic analysis, and we found out a mutation, an RB1 gene as expected. And mother was pregnant 9 to 10 weeks. Parental testing showed no mutation. That means either it could be de novo mutation, probable de novo, the recurrence risk is low. Germline mosaicism discussed with the family, and they went ahead with the pregnancy without prenatal testing. Baby is found to be normal later. So this is how we evaluate a bilateral retinoblastoma, intellectually normal, development normal, and RB1 gene mutation present, parents tested, negative, probable de novo, recurrence is low. Look at this family. Another child with retinoblastoma, bilateral retinoblastoma referred, child yes. He had global developmental delay. So this baby had no developmental issues, intellect was normal, right? Very, very common for any retinoblastoma child. But here there is a developmental delay. After evaluation, MRI confirmed the finding of retinoblastoma, bilateral retinoblastoma, global developmental delay. I will not offer RB1 gene testing for this child because I know this is not RB1 gene abnormality. There is something hidden inside. When we refer, we found out that there is a microdeletion syndrome called 13q microdeletion syndrome, which will be associated with global developmental delay and retinoblastomas. And we offered microarray testing. Parents were not affordable at that time. So this child, retinoblastoma, they didn't want to do the genetic testing. What next we can do? We did DNA storage for this baby. So that it will be available. This DNA storage is available. I know this baby, this is a potentially lethal condition. We knowing that we cannot leave the family as it is without storing anything. So this DNA storage costs around 1,000 rupees. They were affordable. We did that, and the baby died later. Family came with an ongoing pregnancy. So this is very, very common. They will go back, come with an ongoing pregnancy without doing any genetic testing. If This is the trump card here. We had the DNA storage of this baby, and with this DNA storage, I did the microarray testing, and we found out the same reference microdeletion in this baby. Later on, the parents were also tested and they were normal. Recurrence is low, so reissued. So unless you have this one, this DNA storage results, it will be difficult to give a assured results in the next pregnancy. So if you any doubt, family not affordable, store a little bit of DNA of the child, which can be used later. Our 2 years data, total of 143 patients were referred for hereditary germline cancer, and 99 for females, 40 males, and about 73% we have positivity results. So if you see the genetic variations found, the BRCA1 and BRCA2 constitute about 60%. Of course, there are so many other conditions other than breast cancer. There are so many other genetically predisposing mutations identified, germline mutations identified in this group. So neurofibroma, RB1, and then APC, ATM, TP53, so many genes are associated. So look beyond BRCA1 and BRCA2 in case of germline genetic testing. So as from the first slide, we are telling you 8 to 10% of cancers are hereditary. So any person who comes with cancer, think of hereditary, whether this can be a hereditary cancer. We will be focusing on treatment of that particular patients. We will tend to forget that there is an extended family member or this person himself can have another cancer. That risk is there if they have a hereditary genetic mutation which has caused this cancer. So genetic evaluation helps in specialized medical and surgical management. You can tailor down, you can write down all the surveillance protocols, what is the medical management, where this gene expresses, what are all the organs that can be potentially involved, what organs should I surveillance for, should I look for any cancers in the future, how to prevent that. All this information will be available with you if you have a genetic code. Risk reduction measures, once you know this, you know the risks for this person, you can do risk reduction measures. This can be medical or it can be surgical. Surveillance strategies both for the patient as well as career family member who can be asymptomatic also. So test the family member, if they are at risk, offer the same surveillance protocol for them, pick them up early, treat them early so that you won't end up with a high grade disease. So prevention by active surveillance or by prenatal diagnosis is also possible. So do active surveillance, pick up any new cancer, treat it as early as possible. So early prevention is equal to complete cure in cancer. Prenatal diagnosis can be offered in situations where children will get affected, children will get cancers. So those genes we can offer prenatal diagnosis. So now genetic testing of the affected person followed by testing of at-risk family members has become the need of the hour in cancer evaluation. This can do wonders in the lives of families with germline cancer for that particular person, the extended family members, and in the future generations as well. So thank you so much for the patient hearing. If there are any queries, I'll be happy to answer.
I don't think any questions have been posted yet. I would encourage the participants to put out your questions. I would like to thank Dr. Pradeep for that excellent presentation on choosing the right patient testing, choosing the tests, the relevance of interpreting variants of uncertain significance that we come across so often, some of the important management strategies and surveillance methods that had happened. So till the participants pose some questions, I would like to, kind of just ask certain scenarios that we would come across often. So very often we find that patients come with their entire families, sometimes with two, three families together. Once a malignancy has been diagnosed, the entire family wants to know what went wrong. So whether any genetic testing can be done. But how many of them actually do end up doing the testing?
Okay. So now a scenario where we have identified a genetic code in the family. Now next we have planned the surveillance protocol for the index person who is affected. The question is how to extend our genetic search to the extended family members. If you see in the family, I've seen two cohorts, two groups of members. If you offer a genetic testing, somebody will be willing to take it. They will try to use it for their advantage. Another group will be extremely anxious. If I am positive, what I will do? I have to live with that fear forever. So these are two groups. The persons who are willing to come and do the genetic testing to take it head on, or the people who have seen the patient who suffered. A person who's suffering in front of their eyes, they are caretakers, they will know how painful these cancers are. They somehow don't want this cancer at all for them. They will voluntarily come and ask whether I am at risk and how I can prevent this. Another group is they have no idea what a cancer patient is having, that suffering. If this is two groups, unless they get an idea, they will not be voluntarily willing to do the testing. But however, for all these families, we usually tell you use this for your advantage. You have found out a genetic code, you can find out whether you are at risk or not. Having this genetic variation, in case if you turn out to be positive, not all the time they are going to be positive. Only 50% chance is there that they can be positive. Even if you are positive, doesn't mean that you are going to get cancer.
Exactly.
You are at risk than the general population. Knowing this mutation in your body, you are ready. What organs I have to do the surveillance, active surveillance. You will be like doing one master checkup for this particular gene. Anything starts in a point, you can start treating it, come out easily. These are the advantages you have. All these will be explained to the family. And as
And
I
as you
said,
said, variable penetrance.
depends. Variable penetrance is there, so it doesn't mean you will have the clinical manifestation. You are at risk. You be vigilant. Try to identify early and treat. That is the advantage of doing this genetic testing. Lifelong, you will be asymptomatic. That possibility is very much there. And in spite of all these counseling, as I said, two groups of people who have seen or not seen. Who have seen, they will be willing to do. Not seen, they'll be hesitant.
Okay. Then there was one more query which I wanted to ask Dr. Pradeep. So especially when you have mutations in BRCA1 and 2 and you want to test the parents, how ready is the father to undergo the testing? So generally people tend to, segregate the breast cancer and ovarian cancer to the females. But we know that males are also susceptible to the disease. So in our practice, we have found that a lot of times the males are very hesitant to undergo testing. So what is your opinion on that?
Yes, the concept wise, they think if it is a breast cancer, it is for females. They don't know that there is some breast tissue in the males as well, and this can have potential cancer later on if they have the mutation. So we have to tell them that is a concept itself is wrong. We'll explain them that you will also be at risk. So it is better to go ahead and do the testing in both of them, both the parents, and get back with the results. If say if somebody is carrying a BRCA1 mutation, doesn't mean that we will be checking only your breast tissue. Of course, breast tissue is at risk. We will look for pancreas. We will look for prostate. So anywhere else, you have to seek clinically for the signs of cancer. So even if you are male, BRCA1 testing has to be BRCA1 or BRCA2, whatever is found in the family has to be done. We'll explain to
Exactly.
them.
So it is not confined to the breast and the ovarian tissue.
True.
It can increase your genetic predisposition in other tissues as well, like pancreas, prostate, etc.
Yes, yes.
So there's a question here from Anshu. To what extent does consanguinity influence the incidence of cancer within a population? Are there specific situations or cancer types where consanguinity has little or no impact on cancer risk?
Okay. So
Consanguinity and cancer.
cancer, yeah. So this is very, very limited. The consanguinity role, what we mean is autosomal recessive disorders. Autosomal recessive cancers is very, very little. So maybe xeroderma pigmentosa. These are precancerous conditions where a consanguinity plays a role. It can be autosomal recessive. So autosomal recessive group is a very small group. Most of the cancers are autosomal dominant only. So as I showed you one MUTY-H mutation in colonic polyps, that family, that person had autosomal recessive genetic mutation. So consanguinity is an additional point towards whether it can be autosomal recessive or dominant. But anyhow, genetic testing decides that. And we don't have any group of people where they are prone for this sort of cancer. We have not identified anything like that, and so the consanguinity role in cancer testing is limited, not like pediatric genetic testing in immunism, metabolism, developmental delays. Here the role is little limited only, and because most of the cancer genes are autosomal dominant. That was a great question. Thank you so much.
Yeah, so, all right. Are there any further questions? I don't think so. All right. So, Dr. Pradeep, I just want you to reinforce the role of prenatal diagnosis for these germline cancers for the benefit of our audience. So,
Yeah.
very often we get requests saying, I don't want my child to suffer the same way as I did for adult onset disorders. No, they might have undergone through a very terrible period, and they say, I don't want my child to even have these disorders. So, how do you counsel the families when you are faced with such a situation? Though
Yes.
many of them are open, they don't want to test. There are a few, especially the grandparents who come and say, I went through such a lot. And so how do you counsel such families?
So it depends on the mutation identified in the family. Whether this mutation is likely to affect the child in the childhood age or not. Say for TP53 leaf harmony, we know it is going to affect even a child. So if that mutation is found out, nobody is going to, we are going to offer a prenatal diagnosis. The question comes where this is an adult onset disease or there is variable penetrance. We don't know whether the clinical manifestation will happen or not. There, doing a prenatal testing. Doing a prenatal testing doesn't stop with the diagnosis. We have to take decisions. Taking decisions whether to continue the pregnancy or not based on the prenatal diagnosis is not recommended for adult onset diseases, particularly like BRCA1 and BRCA2. On the other hand, if they are very, very particular, maybe we can offer PGT-M, that you can test an embryo and select an embryo. You cannot test a fetus and filter that fetus. For an adult onset or varied penetrance diseases, that is the guideline as of now. We have to
So
put it
termination
forward
is
in
very
front. Yes.
painful.
Yes.
Termination would be very painful in such a situation
And
too.
it is not recommended also. We cannot do it also. It is not recommended. It is not, actually no guidelines has given us that. It is contraindicated as far as I know. Your opinion, ma'am?
Definitely. So we do not recommend prenatal for adult onset hereditary cancers at all. Okay, so as per the recommendations, we too don't do it. This diagnosis of a genetic positivity of a hereditary cancer in an asymptomatic patient sometimes can trigger a lot of anxiety. So do you have a psychologist to help you out, or how do you deal with the anxiety part?
Yes, ma'am. Definitely. If it is uncontrollable, if they're not settling down, each and every visit, they are in so much of anxiety, repeating the same questions again and again. That means that person is unable to handle this information. So initially, when we talk to them, everybody will have a little bit of anger. They'll be upset. They will get depressed. Over a period of time, they'll come out of it. They'll understand the science behind this, and then they start acting on it. This is what we expect. Whenever we break a bad news, over a period, this person will come out of that group and they will start working on that. If that is not happening, then that person needs a professional help. A psychiatrist or psychologist counseling is very much needed. And again, we have to talk to the psychologist, tell them about everything, because they may not be knowing about this one, the positive points, like this may not happen also, this is just for their advantage. All these we have to explain to psychologists, then they have to counsel accordingly. It
Right.
depends on the type of the personality, ma'am. Yeah.
Right. So thank you very much, Dr.
Thank you,
Pradeep.
ma'am. Thank you.
Thank you. That was an excellent presentation and excellent clarification. So any further questions? I don't think so there are any. So Chetna, can we close the session then?
Yes, ma'am.
Okay. Thank you very much to one and all. And thank you, Dr. Pradeep, for that excellent session.
Thank you, ma'am. Thank you all.
Thank you so much, doctor. Very informative session. Thank you.
Oh,
Thank you,
thanks,
ma'am.
Thank you, ma'am. Thank you. Okay.